Hi. Welcome, everybody, to Knock Knock Hi with the Glaucomfleckens. I am Dr. Glaucomflecken, also known as Will Flannery, and as my government name. And we have here Kristen Flannery.
That's me, also known as Lady Glaucomflecken, not my government name.
No, we are the Glaucomfleckens, and this is our first episode.
Very first one.
This
Brand
is
new
it.
podcast.
We've been wanting to do this for so long. We've talked
so
about
excited.
a podcast.
We have.
And I mean, people tell me I have like kind of a
radio voice.
Maybe not a radio voice.
Radio face.
But actually, some of my videos, people say it'd be a good voice to fall asleep to. So I hope that doesn't backfire on us.
Yeah.
Because
if you're driving, you might want to pull over just in case.
Yes. That's so you could probably keep going. Just, turn the AC up.
Yeah.
Is that your go-to move? That's my move.
Is it? No, I use gum.
Really?
Yeah, chew some gum.
Oh, you chew gum to keep yourself awake. Okay. Going through medical education and training, you have to figure out ways to keep yourself awake.
Sure.
And so that's
legal
one of
ones,
mine.
please. We don't.
Oh, absolutely, absolutely. So, what are we doing this for?
Yeah, what are we doing this for? Why do you want to do this?
Well, my big thing is I love introducing humor into healthcare. Obviously, those of you who've seen my videos, I like to dress up as different characters in medicine and record myself alone in my bedroom.
Mm-hmm. It's a little weird, I'm not going to lie.
A little strange for a hobby, but and then I post these videos to TikTok, which is an app dominated by 18-year-olds.
Yeah.
Yep. And so, except I'm a 37-year-old.
When you put it like that,
physician.
You sound like you could be a criminal.
Well, it's we haven't
ruled it out.
I have not broken any laws yet that I'm aware of.
Okay, good. Please don't.
And so I have turned myself into this comedian / ophthalmologist, which is a combination that doesn't make any sense.
No.
But it is what it is.
But that checks out for you.
But I'm also, want to do more than just, 1 to 2 minute clips. And so the podcast was born as a way to try to introduce a little bit of levity, a little bit of personality to medicine, and as a way to really show people that doctors can be like normal people.
Are humans,
and have normal conversations and tell jokes and have fun. And that's what we're going to be doing on this podcast.
Yeah, and it's like I always told you in medical school that before you are a doctor or a medical professional, you're a human. And we need to honor our humanity before anything else.
Yeah, and so we'll be talking with each other, sharing laughs, talking about our lives a little bit, and also having lots of guests on from the medical community. Some of them are doctors. Some of them are people that played doctors on TV. But what we're going to be doing is telling stories about people's experience in healthcare. These stories are at times embarrassing, sometimes harrowing, sometimes
disgusting. There's a lot of
little bit of disgusting from someone who's not in medicine. Kristen is not.
I'm not medical
whatsoever
in any way by choice.
What do you do?
A lot of things.
You want to tell people what you do?
I've had a very windy path. Mostly, I am in marketing and communications now, but by way of some other things.
Not in medicine.
Not in medicine. Not in any way. I'm mostly into still people though, just not their bodies, more their minds.
But what we'll be doing is really kind of telling the stories that people don't hear a lot about, a certain side of healthcare and medicine that is a little off the beaten path a little bit. So we're excited. We don't know where this is going to take us. Who knows what it will look like, months from now. But we're just going to kind of, go with it. And we're excited for you to be here with us, listening to us on our first episode.
Yes.
All right. So we appreciate that you're all here. Should we get to today's guest?
Sure. Let's do it.
So today we're very excited. We're starting off with a bang here, you guys. Dr. Muneeb Shah. The Derm Doctor. That's what a lot of people know him as, the Derm Doctor on TikTok. This guy's He's everywhere. He's got millions, I think 15, 16 million followers
20,
on
maybe
TikTok.
more.
And he's a practicing dermatologist in North Carolina. And he has done a fantastic job over the last few years educating the public about skin.
Right. He really uses social media as a tool for medicine to, educate patients outside of just the traditional clinic settings.
And not surprisingly, he has garnered an enormous following because people are thirsting for skincare tips.
Oh, yes.
And knowledge. And so we're going to talk to him about all that. We're going to hear some of his stories and have some fun doing this. So
Why do you think, Will, that all dermatologists seem to be just beautiful people? What are they drinking?
I think they really just know how to, like, what to put on their skin.
They just know their stuff.
People like me, my skincare routine is
non-existent.
Yeah.
Yeah, we share a bathroom, I know.
I don't have one.
Right.
And so all dermatologists have one. And
Yeah.
I think that's the difference.
Yeah, sure.
Take care of your skin, everybody. Listen to what the Derm Doctor has to say. Go check out his social media channels because maybe you too can have amazing skin. All right. Well, should we get going?
Yeah, let's do it.
Let's do it. Here we go with the Derm Doctor. All right, we have Shah, the Derm Doctor, here. Thank you so much for joining us. We're so excited. Yeah, I've obviously seen you all over social media. It's nice to finally get to see you face to face. This is great. Welcome.
Well, first of all, thank you for having me on. You are the leader of this specifically the comedy, but the med space. I mean, I think everyone knows you and loves you. And I don't think a lot of people know that you're an OG. You're before TikTok, before Reels, before YouTube.
Yeah.
I think Med Twitter, and then even Gomer Blog. Am I wrong or am I right?
You did your research.
You're going back to the Gomer Blog days. Yeah, that was, and then I wasted a ton of time on Twitter before I realized that video was like the thing, right? Which you were on, you're like meteoric rise on TikTok. I mean, did you ever expect it to take off like this?
No, I had no idea. I was just having fun. I think a lot of us that make content are creative people. And so I was just having fun, and then it took off. And then it was actually my program director, because I was in residency at the time, who told me, you need to really take this seriously because you can reach so many people with information that it would take, decades for you to reach in real life. So you should really buckle down and make good content.
Good for your program director.
Yeah, that's a pretty progressive attitude right now.
Yeah, because you see a lot of trainees, a lot of med students, they're anonymous on social media, right? Because they're afraid of some kind of backlash from doing
their programs, yeah.
Yeah, but that's great. I'm glad you got that encouragement early on. I want to ask you something that Kristen asked me just the other day about how much of your audience do you think is medical versus non-medical? Or really the question she asked me was, or it wasn't really a question, it was something along the lines of, why on earth would non-medical people ever listen to you
That was
and
verbatim.
watch you?
Yeah.
So anyway, I would like to hear from you. Like, do you have a sense for your...
I totally understand for him. I don't get it for you. But for him, I mean,
Yeah, tell us.
You answer, and then I'll see if it matches what I'm thinking.
Yeah, I would say medical, probably 1%, maybe.
Yeah, that's
of
what
my
I would
audience.
guess for you.
Most, because I make my content for the public, right? Like the way that I speak, the terms that I use, the way that I present information, really starts at the basics and then builds on that. So I actually intentionally make content for the public and not the medical community. And there's dermatologists that make content for the medical community. I'm not one of those people. So I would assume you get too many views for it to just be the medical community. So there must be people that love this genre of comedy that you have.
And it seems like inside jokes to the medical community. So that's why I'm always interested when people outside of the medical community are such fans, because, that I think is just, I don't know. It's something
I came to it
dive
from
into.
the opposite perspective from you. Whenever I make a video, it's like I'm thinking of it from the perspective of a physician and making stuff that I think that the medical community would enjoy. And it just so happens that people outside of medicine watch it. And I'm still a little bit confused as to why that is, but I'm going to accept it. I'm going to take it.
I think there's this like educational byproduct, right, for people. It's just like they get an inside peek into, behind the curtain of the medical community in an approachable way.
But I'm so impressed by what you do because, oh man, the amount of people you reach and the information that you give them is like, we need more of that. Like, I really should be doing more like, educational things, but I don't think I don't have that in me. I can tell people not to use Visine and stuff, but like, it's really all the stuff about like, cancer screening and wearing sunscreen and all. It's just like, it's really fantastic.
Well, okay. And here's I won't go so far as to call it a beef, but as a woman, a person identifying as a woman, I feel like there's a whole, and you guys overlap on this a little bit, but mostly for dermatology, there's a whole beauty industry component to dermatology that I feel like, I just want somebody, what I go to when I'm looking for products is not the beauty industry because they're trying to sell stuff to me. So I go to, the dermatologists and I try to see what are they actually using and why. And, do you need the fancy designer products that costs hundreds of dollars or more, or can you get by with the, drugstore CeraVe and all of those Neutrogena? Like what is the actual ingredient that's doing something and what's just, garbage?
We need you to make us beautiful. We need you to make us beautiful. Help us.
You're both beautiful,
Shah.
so you need no help from me. No, you're right. So I think that the beauty community is interesting because you have derms, you have estheticians, you have just people that are enthusiasts that are making content. And we actually need all of them because they all present differing opinions. Like I may not be relatable to the average beauty consumer or a subsect of the beauty consumers. And so there needs to be somebody who can reach them and communicate good information to them. So I actually look at it as like the derms are part of this whole thing. Like it's not, they lead it. They don't like, they're not the ones that are vetting the information. They're part of this. And people like you, you might find an influencer you like that recommends a product. And then your check might be to see what the derms are saying about that product. And I think that makes it a really good place to be. But it just so happens that beauty plays really well on social and it's very visual. So as a derm on social media, I have so many opportunities to make content and react to different things that people are doing. So I had this endless stream of content that people are giving me.
Yes, but also you guys are onto something because all of you are beautiful. So you're doing something like, look
She's talking
at
about
skin.
you, not me.
Yeah, no. Look, it's glowing.
It's good lighting is what it is. It's,
right.
It's
well, you do seem to
here.
be glowing even through a computer screen.
Yes.
It's maybe one thing that you've also noticed is that it's the same thing with eye care. Like people just don't know anything about it. It's this very this area of medicine that's even as a medical professional, you don't get a lot of experience in it, and so there's this huge knowledge gap. Really with the general public, but also with medical professionals. It's the same thing in my field. I'm sure it's the same thing that you find in your field, and so even people in medicine appreciate all that beauty and even the non, just anything. Just give us information, about the skin, the largest organ in the body, by the way.
That's what is the eye the smallest organ in the body? Then
Ooh, good question.
It depends on what you think of the pituitary. I think that might win, but
is that considered an organ?
Also,
I thought that was a
I'm not sure what the average testicle size is.
Oh dear.
But that
God, maybe comparable. Yeah.
I don't know. I don't know.
You
Actually,
do?
I did
Okay.
radiology, and we would measure the before derm. I was actually a radiology resident, and we used to measure the volume on ultrasound of testicles.
Okay.
So I do have an idea of the volume of a testicle.
Ooh, do you know the volume of an eye?
Of course, I know the volume of an eye.
Okay. Well, here you can
What do
answer
take me
this
for?
question. Which one's
it's
bigger?
about we have about 20 mils, 20,
Okay.
20
Okay.
something like that.
What do you got?
I don't know.
I don't know. I don't remember.
Oh, he doesn't remember.
I didn't know I was going to be quizzed on this. I can't remember.
Neither
that
did
far
we.
back.
Somehow we always end up talking about testicles, though.
It's all
Yeah.
just it's all balls. It's whatever. Anyway, I want you to have time for you to tell a story. Did you bring a story for us today?
I have stories, but
I'm
I
sure
want
you
to
have a
continue
lot.
the thought of the basic. I think basics for medical people that are listening to this, it's the basics that the public wants to know. Because
Yes.
I think if you're think about you and me, we don't know anything about law. We don't know anything about accounting. We don't know anything about car. Maybe you know something about cars. I don't. So it's the basics that I want to know when I'm approaching these experts, right? And you can't talk to me up here because I'll never get up here. You need to start here. So I think for you and me, even the simple things that seem simple to us are actually really beneficial to people, and that's why I always start with the basics. But yes, I have some stories, some embarrassing
please.
stories.
Oh, let's
Oh,
hear it.
good.
That's good. We all love a good embarrassing story. Let's hear it.
Well, let's start at the low hanging fruit. Medicine
Testicles
is
again?
interesting. Yes, exactly. And now on to no. So, one of the things is that a lot of us didn't go to lecture potentially in med school. I don't know about you, but I used to read a lot. I used to everything I learned from reading textbooks, and then diving deeper in those textbooks. And so a lot of things I actually didn't know how to say, but I knew what I thought they sounded like.
Right.
And so getting into third year of medical school where you actually start seeing patients and you have to now present what you've learned out loud to people for the first time. I mean, there are so many instances I can think of where I got clowned on for the words that I said. One of the things is I used to present the lab values, and when I would say bun instead of BUN. And oh man, they got me on that one. They're like, bun, and I'm like, oh, I've never realized this was an acronym for so that's one low hanging fruit. Another one is spirochete. I thought it was spirochete. I don't know,
Sure.
how would
That
you know
sounds
otherwise?
Right.
Yeah.
How would
Well,
you
you
know?
make it sound fancier.
It's
That's for
French.
sure. Yeah,
Right. It's
spirochete.
exactly.
Make the T silent. Spirochete.
I don't think that's not too bad. That's so. I mean, it's obviously wrong, but it's okay. I don't blame you for that.
It's not too bad. Yeah. No, it's not awful. Good stories wise is.
Can I give you? Because I have a very similar experience in certain ways. So I remember just in relation to that being in lecture. And I asked a question about contraindications for something. And so my whole class was there, or a whole class, probably 20 people.
Yeah.
I don't know. You know how it is, going to class. But instead of contraindication, I'd never heard that word spoken out loud. And so I said contraindication.
Oh boy.
Contraindication. And of course, the whoever the professor attending was, called me out on it immediately. Oh, you mean contraindication? It was the most embarrassing thing that I'd experienced.
You should have just held your ground. No, I mean contraindication.
I did not have that much confidence as a first year.
Be like,
med
no, you're
student.
wrong. You're wrong.
Yeah, right.
No.
To tell not a road you want to go down when you're telling attendings that they're wrong as a first year med student.
Well, now you're bringing in words that are non-medical, and I could tell you one for me. You know the word disheveled, right?
Oh yeah.
I whenever I'm reading Harry Potter, as a kid, for the longest time, and I said this out loud, I thought disheveled was disheveled. I thought the dis was
Yeah.
separate from the sh. So I thought it was disheveled, and I used to say it disheveled out loud to people. So that's tough. That's also tough.
Well, it's a sign of
Of a reader who's
reader.
advanced, right? Because you're reading words you've never actually heard before in regular vocabulary.
That's fair.
Sorry,
And this
yeah.
is before you could, or maybe you could, where you could type in words on Google and say, how do you pronounce this?
Right. Exactly.
Well, so what else do you got? You got something else embarrassing? I love.
got
Let's
some
hear the
stories.
Derm doctor who has I don't know, 220 million people following him. I'm sure all of your fans would love more embarrassing stories about you.
Embarrassing. Well, I have a good story. It's not an embarrassing story, but it's a motivational story for those of you who are
That's
out there who
good.
want to achieve high levels of success in whatever industry that you're in. So I'm an intern. We're on rounds, and when people have strokes, sometimes they develop bowel incontinence, right? They can't hold their stool in, right? And this is an expected outcome, right? We always check for this to make sure that people have fecal continence or incontinence, and we're on rounds, and part of the rehab process is that we try to get these people walking as quickly as possible with physical therapy to get them better. Like you really have to get these people moving, especially after they have some type of stroke like this. So we're on rounds, and this gentleman is walking, and he's in a gown, but he's not wearing underwear. And so he's walking, and he drops the perfect turd on the ground. And this is expected. So no one's upset at him, right? Like this is, this is what happens, right? And, actually he got much better and, was discharged soon after that. But he drops a perfect turd. And it was like coin size. Like it was round. It wasn't messy. It just it plopped on the ground, and it plopped in front of all of us. And there's about 12 of us sitting there on rounds, and we look down. We look up, we all kind of look at each other because now somebody has to respond to this. Somebody has to do something about this, right?
Right.
And there's just one guy, he's a fourth-year medical student, and without hesitation, he puts on a glove, picks it up, brings it to the trash, throws it in the garbage, and then just comes back. And I thought to myself, like, this is a guy who's going to go far in life. This is the person who responds in the time of need without hesitation. No one asked him to do anything. I wish I was the one who responded. But this guy got 5s across the board on my evaluation.
That's
he ended
quick
up
thinking.
going on to be an ENT. And so that's my motivation for you. When there's a turd, be the first one to pick it up.
Pick it up.
Yeah.
Absolutely. I love that. That's and it's funny as a med student, like your mindset and your clinical rotations is always to just be helpful, right? You want to, because you don't have a lot of the knowledge base, so you want to be able to do anything you can, helping patients in and out of chairs. Like that was my specialty.
Well, you're very tall
On rotations.
so
Like I was
works.
great at helping people in and out of wheelchairs, moving, transition, like learning from the nurses, like how to do that, like safely. I was great at that. And especially opening doors for other people. That's another classic. But your point is a good one. It just find ways to be helpful and to be and to. I'm sure the patient probably appreciated that as well, right?
Well, hopefully the patient never knew, because that would be mortifying.
The patient didn't know.
I like that he just said it or did it and didn't say anything.
Yeah,
that's
the patient
true.
never knew.
Yeah.
No one laughed about that. The patient is the patient, right? Like that, there's an expected outcome. But like you said, like being helpful is really will get you far in life in any situation. In residency, I mean, I can tell you that just trying to be helpful and doing your best and going above and beyond for your patients and listening to the nurses, because part of my training was at a VA hospital. Of course there's understaffing issues there, and there's issues with like communication, and there's a war between the residents and the rest of the staff, and ultimately if you just listen to them and do your best, you tend to succeed, and they go out of their way to help you. And so that's something I learned super early on, and it made my whole intern year and beyond much easier for me and everybody else. So I don't fight the war. I just we try to create alliances along the way.
Where were you doing your intern year?
At Albany Medical Center, which is it's a level 1 trauma in like upstate New York area. So we were busy. We were definitely busy, but it was actually probably my favorite year of residency, even though I worked the most, because after that I went into radiology, and then I transferred into Derm. And so it only got easier for me as things went along. And so intern year was the toughest year hour-wise, but it was actually probably the most fulfilling and fun year for me. And I learned a lot about myself, so a lot of my good stories come from intern year.
Oh yeah. It's the biggest way. What am I trying to say?
Like learning curve.
The biggest learning curve. That's it. The biggest learning curve is intern year. Like it's because you're just thrown into the fire. All of a sudden, just like last week, you were a med student unable to order Tylenol, and all of a sudden now you can, and among other things you can order. And so it's this huge change, pretty suddenly, to be honest.
Also, like in ophthalmology and probably derm, I would guess it's probably the last time you do like real medicine, right? And then you transition into your cush jobs.
She's yeah, she knows. She knows. She knows what it's like for me, like on call, and
I've heard all the calls along the way.
Yeah. So
Right.
and
These
she
ones
also
are
knows,
not bad.
She also knows that immediately upon beginning my ophthalmology residency, all the medical knowledge, the general medical knowledge, anything below the nasal bridge, I was dumping that information. I don't know but see, dermatology is different.
I mean, they do have to do like the whole body.
No,
the skin
yeah.
is everywhere.
Right, skin covers everything, and one of the I think the coolest things about dermatologists is that there can be just some seemingly inconsequential little thing on the skin, and then all of a sudden a dermatologist be like, "Oh yeah, that's liver cancer."
Right.
It's like
black magic.
I don't know how you do it. And it probably speaks to the fact that you still have to hold on to all of that general medical knowledge and know those systemic manifestations of things.
Yeah, whereas he can't even like tell if our kid has a cold or something. I'm like, you need a mom if you're a
I'm
parent.
not that bad, but anyway. What do you think? Yeah.
No, I agree. So derm is, yes, like, even during residency, like the stuff they quiz us on, we need to know every type of Ehlers-Danlos syndrome. We're still learning about like osteogenesis imperfecta, every, glycogen storage disease. They still test us on these things because a lot of conditions have skin manifestations, and derms are sometimes the first people to recognize these things. So we need to know all the signs of neurofibromatosis and tuberous sclerosis. And, this is part of our curriculum because, like you said, the skin is sometimes like a marker to something deeper going inside that's much worse. And so, a lot of like, you've heard the quote, I think it was like the first line of first aid for the boards, which was, you may be the only thing standing between a person and death. Right. And so, as a physician, like you do need to know everything you possibly can, like if that's your domain, right? Because like if they come to see me and I'm the specialist in derm and I don't know the skin thing, right? Or I don't have a plan of action of what I'm going to do next. Like, where do they go next, right? Like, like if someone comes to you about an eye condition and you're like, well, I don't know, and I have no plan for you next, that's a tough thing. So I think, we try to at least know the most of our domain as possible because it's really important.
What do you do? What do you do when because we've all had those situations where I really am not sure what this is, what's going on. What is your next kind of course of action?
This is such a good question because my, where I trained, my program director is very like, kind of going back, he saw the writing on the wall for social media and the importance of what I was doing. He's very forward thinking, very logical, very common sense based. And he kind of sat us down one day and he said, listen, like there's going to be many times in your career where people are going to come in and you're going to have no idea. And he said, the number one thing you need to do is give them a plan for the future. And that's it, right? Because you're not going to know everything. And so like, you need to know what you're going to do next. So he's like, I walk in, he goes, I give them a list of things we're going to do. I take a biopsy or I order labs to get more information, to buy time. And then I see them back in 2 weeks. And during that time, I have now more information to act on and I've given them some type of treatment. And so that patient knows during that 2 weeks that this is the plan. I'm going to see you back in 2 weeks and we're going to discuss further steps after we have more information. But that confidence level, right? And not saying, say, hey, I'm not really sure. I think it's these possible 3 things, but we're going to get more information and we'll know more in 2 weeks. That gives them confidence, even though you don't know, right? And it's how you present yourself. And so that happens every day. And for some reason, like as soon as I graduated, like it seemed to happen more. I don't know if that's, you just have more doubt in yourself or you're seeing like a new selection of patients, but it's like every patient that walked in my first week, I'm like, I'm not sure about this one. Like, but then you just give them that confidence that you're going to find out and you're going to be on their side through that process and coach them through it. And I think people appreciate that and they feel like they still have trust in you than lying and say you know something and you don't.
Right. How many years are you out of training?
Like 6 months.
Okay. All right.
Yeah.
I'm about 5 years out of training, but I still remember that first like year really, where you do have that doubt. Like, am I smart enough? Am I capable enough to like have all these patients coming in and it's up to me to find the answer. And I was regularly like consulting my, textbooks, Google, there's, you kind of know, but you want to just be sure. And so, I tell residents this as like, it's okay to like excuse yourself and go look at your, for us, it's like the Will's Eye Manual or some other textbook or Up to Date or whatever it is. Like, it's okay to excuse yourself and go and make sure you know the right answer, whatever the dose is for that medication.
How do you do that? I want to know. I want some tips here because do you say, hey, I'm going to look this up and then you leave, or do you come? Because I usually come up with an excuse. I'm going to be honest. To be honest with the public right now.
Right.
I'm usually like, all right, I'm going to go grab something from the back, and I'll be diving deeper or confirming, right? Because you don't know the doses of everything.
That's exactly what I usually said. Well, I was like, listen, it could be this, or this. What I'm going to do is I'm going to do a little bit of research, or I'm going to, just consult one of my partners, or, do a little bit of digging to just make sure we have the right plan for you. And I've never gotten any like negative feedback from saying something like that, because like you said, patients, they like knowing that you're doing everything in your power to come up with the answer. And that's what counts.
Yeah. And just speaking as a non-medical person who has been a patient, continues to be a patient, it's in the age of Google, like I do not expect anyone, doctors or otherwise, to just have everything memorized and, downloaded to their brain. That's just not the way the world works anymore. So I don't think twice if somebody says, I'm going to go check something real quick. In fact, if you're honest with me about that, you don't have it all memorized, you don't have every answer top of mind, I'm going to trust you more because you're a human, not a robot. So, if you're pretending like you know everything, I'm actually suspicious.
Yeah.
So if you go and you say like, here's what I'm thinking, here are the questions I still have, let me go find out the answer to those questions. What I'm coming to you for is I trust your ability to Google this better than my ability to Google this, because you have all the background knowledge to know what's good information, what information might relate to other information. Like those are the things about, it's not about do you have access to the knowledge? We all have access to the knowledge now. It's what to do with that knowledge and how to apply that knowledge in a way that I just don't, because I don't have the training you do.
I also think it's super cool that you can biopsy things that you're not sure about, because it's harder to do on the eyeball.
Yeah, right. You can't, what they say is tissue is the issue. You can't get the tissue. There's not enough volume, like we said,
right,
for you to get the right sampling. But yeah, no, I think you have a good point. Everything is on Google. In fact, like everything that we know is on Google, and it really is being able to discern what is accurate and relevant to that particular patient.
Right.
That is what our training is, when we're practicing that art of medicine. Because otherwise, like that information is out there in volumes, right? Like you can find anything as a patient, and there's more information on Google than there is in my brain, but I can discern like, okay, this is relevant, this isn't relevant, this is not cancer, right? You're not going to die.
Right.
I think this is benign. And, I kind of like, move through that information much quicker and are able to come up with a good diagnosis or a good treatment based on that. So yeah, 100%. Right. I like that as a patient, you can recognize that we're able to discern the information rather than know it all.
I'm coming to you for your critical thinking, not for your memorization skills. Yeah.
But and then you also mentioned a really important point when you said, you're this isn't cancer, kind of thing, because very frequently I'll tell people, you're not going blind, and it's amazing how many people are like reassured by that fact. They have something going on. They honestly think they're going to lose their vision. And just by telling them that, like that, it allays so much of their fear. And so,
it's human nature just to go to the worst case scenarios when you don't know, when there's uncertainty, you get scared. And so, yeah, it's really important, I think, for doctors to realize some of the basic stuff that you guys know that, okay, this is not a concerning issue. When that doesn't actually get spoken out loud to the patient, they don't know that. In fact, they're still worried that it is a concerning issue. So I like that, to say it's not cancer, you're not going blind, whatever the issue is, before you dive into what it actually is.
That's it's really interesting that you say that, because there are things I definitely took for granted when I was going through my training, which was, I do a lot of surgery on the face. And in that process, I always think about what type of scar this person is going to have. And part of my closing, when I'm planning the closure to put the skin back together, I try to orient everything in a way to make the scar look as invisible as possible. And a lot of times when I'm presenting information to patients, I'm like, oh, don't worry, I'm going to do the best job to make the scar look as small as possible, because I know that this cancer is not bad, and if I remove it, it's gone, and that they have nothing to worry about. But they actually don't know that. And a lot of times I'm worried about the scar because I know I'm going to get the cancer, but they're actually worried about the cancer still. So a lot of people are like, I don't care about the scar. Like, I just want to know that I'm
get the cancer out of here.
Die. Just get the cancer out. So, so I had to start to reframe, because I actually took for granted that missing piece of, like, they just want to know that they're going to be okay. And so I think you can learn a lot from listening to your patients.
Yeah.
100%.
Great conversation. We're going to take a break. Let's do that. And then we're going to come back with Dr. Shah, and we're going to play a game that I call Adventure Diagnosis.
Ooh, I don't know if I like that.
You'll love it. We'll be right back. Just want to give a big thank you to all our listeners joining us right here at the beginning of our podcast. Episode 1. You're here. This is a new show. Spread the love. Share with people you know. Just everybody. Just tell everyone about Knock Knock High. Leave a rating. Be honest. It's okay. Like, we can take it. Tell us what you think. We want to hear. We want to create a community here.
That's for you guys. Yeah.
For all of you. Later today on this episode, we're going to share some stories, some of your own medical stories from people in the community, the Knock Knock High community. You can share yours, Knock Knock High, at human-content.com. And we also have another episode out now.
Yeah,
we
do.
2 episodes in one, basically.
First, listen to this one.
Yeah, listen to this one. Okay, and then go and check out our second episode with Dr. Jen Gunter, available now.
Yes, she is amazing.
We also have a Patreon. Come hang out with other members of the Knock Knock High community.
Including us.
We'll be there. Early episode access. Check out bonus episodes there as well, including a whole Patreon exclusive called The Monthly Eye Exam, where Kristen and I react to medical TV shows and movies. It's going to be a lot of fun.
So come play.
Now let's get back to Dr. Shah. We're going to play a game. This will be fun. All right, and we're back, and we are going to play a game. Hope that's okay with you. I think this will be fun, because one of the things with dermatology, from a healthcare professional standpoint, is you have your own language for things.
Okay.
Right.
Okay.
Ophthalmology is the same way. We have this whole vocabulary that no one knows anything about. It's really the kind of similar, with how you describe rashes and skin findings and things. And so I thought maybe we could do something that might help the public a little bit and other medical professionals on describing things. And so what we're going to do, this is called, I made up this name, Adventure Diagnosis. It's stupid, but I'm going to tell a story. All right.
Okay.
And during this story, things will happen that will result in a rash. All right. And it's your job to describe that rash. All right.
Ooh, okay.
Okay. You're going to describe this is going to be super easy for you. Although I did throw a couple of different curveballs in here. Okay. So here we go. Here's the story. The 3 of us are going on a hike. All right. You, Kristen, and myself, because we like to hike, right? Do you like to hike? Do you go? Of course you do. If you submitted a med school application, you love to hike.
I do like no form of outside activities, actually.
Okay, you're gonna pretend that
I'm
you
an
like
indoor kid.
that
so
you like to hike. Okay, honestly, I don't really like hiking that much
Okay,
either.
none of
But
us
anyway,
like to hike,
that's
but
what
we're hiking.
that's what we're doing. We're going on a hike. All right, and so we're starting on this hike, and I realized that I need a walking stick. I like to have a walking stick, so I wade into some nearby bushes to obtain a hiking stick. And then Kristen points out that I'm actually walking through these very suspicious looking leaves of 3.
Mm.
And then pretty soon I notice some burning.
Mm.
What? But
What's going on?
What's going on? So if it's that quickly, probably nothing. Other than maybe you got
I was
bit by
gonna say, is
something.
it when
Assume it's happening immediately.
is the burning when you
Immediately
pee,
happening.
or you got to be more specific?
It's poison ivy.
So I know.
What-
so for
what
the
do
medical
you see?
people out there, it's a type 4 hypersensitivity reaction. So it takes a little time to react. But for the story purposes,
Yes.
what am I seeing? So it's red. It's people say erythematous, but red is actually the right way to describe it. Is based on the color.
Oh.
So it's red. It's red. It's usually vesicular, which means that it has fluid-filled blisters, essentially small fluid-filled blisters. So red, vesicular, and pruritic, also known as itchy. And those are usually the way that you describe it. And it's usually in a linear pattern in the way that the tree brushed up against you. So a lot of times the way the pattern looks and the distribution of this rash point us in the direction of poison ivy dermatitis.
There you go. I could listen to you talk about rashes all day. Okay, here we go. All right. So unfortunately, I now have poison ivy. But we continue going. We walk into a large exposed area of this trail, like a large meadow. All right. And the sun is beating down on us. And unfortunately, I forgot to wear my sunscreen. And I know that I'm with a dermatologist, so I'm afraid to tell you. And I'm afraid to all of a sudden just apply sunscreen. And I experienced the consequences of that.
So
Tell me.
sunburn, right? So we're talking about
Sunburn.
sunburn.
I got a
in this
sunburn.
scenario. So what does this look like, right? So a lot of times just red, erythematous, a lot of times blanching, right? Like when you put your finger on it, the red, disperses and it's white that's left behind. So that's a blanching rash. And it's just diffusely red and homogeneous in its red color, right? So it's not like little patches of red. It's usually like fully red. And then it goes through this process where as your skin dies off, you start to peel a lot of times. So your skin starts to peel off, and you get some scaling and flaking that occurs afterwards as that epidermis lifts off of.
When
It
was the
sounds
last-
like in this story, I have never been more attracted to you.
Yeah, that's
Right. So
this
now-
it's gonna
You
get
you
worse.
now have
It
poison
gets
ivy
worse.
and
Okay.
Oh, it's getting much
are
worse.
scaly and
It's getting-
flaky.
When was the last time you had a sunburn, Shah?
Ooh, be honest.
Sunburn, probably actually when I was a radiology resident in Morocco.
No, you didn't.
I
You
think
never
I got
went in the sun if you were a radiology resident.
I know. We went on vacation, and so my skin wasn't prepped for the sun because I had been in the dark room for so long, and then
Gotcha.
yeah, not a bad sunburn because I have a skin tone that doesn't really
Yeah.
burn that easily.
Well, I'm sure that would be grounds for probably removal from your practice if you ever showed up with a sunburn.
Right.
Okay, so I got a sunburn now. After a couple hours, all right, we take a break. All right, much needed break. Unfortunately, I choose to sit on a log that's directly underneath a beehive. All right, bad news. The bees start chasing me. I'm running wildly down the trail. I'm shouting, "Help! Help! I'm allergic to bees." Despite all my evasive maneuvering, an angry bee catches up to me and stings me right on the face. What happens next?
What happens next? Yeah, I mean, you're allergic to bees. So this is opposite of the poison ivy situation where it's a type 1 type of reaction, type 1 hypersensitivity. So it's immediate reaction. So what ends up happening a lot of times, you get pain, you get swelling, you get a little nodule at the site that's red and sometimes indurated or hard. And then the rest of you get a vasodilatory response. So you get flush, you basically start, your blood pressure drops. You get swelling inside your throat. You can't breathe. Your face starts to get really swollen. Your eyes get swollen and edematous, which is another word for just kind of fluid leaking out into the tissue. And then, you can't breathe.
Sounds
and then we hit
awful.
you with the EpiPen to
Yeah,
save your
unfortunately,
life.
you did bring an EpiPen. So you get me with the EpiPen, and I'm okay. But despite the poison ivy, the sunburn, and now like an anaphylactic reaction to a bee sting, we continue on.
We
continue.
can. Wow. Okay. This is why I don't go outside.
We are
This
motivated.
is exactly.
We are
the reason.
motivated.
Outside is
We
dangerous.
are motivated hikers. All right. All of a sudden, we come across a second group of hikers. One of the people in the second group is a non-dermatology physician. We'll say an internist. And once they find out that you, Dr. Shah, are a dermatologist, they begin telling you all about a rash that they saw recently. How did the person describe this rash? This is a trick question. It's a
maculopapular. Yeah.
Maculopapular.
Yeah.
Which
I don't hate that phrase. Like most
really you
derms
don't
do.
because I think we're all conditioned to assume that that's something you never say in the presence of a dermatologist.
Yeah, well, because we don't necessarily describe, but it's pretty accurate, as far as like a description of the rash, right? It's raised and flat. There's a papular component and then there's a macular component. And I'm like, well, yeah, I kind of know what you're talking about more than morbilliform. Morbilliform doesn't sound as descriptive to me as maculopapular.
So morbilliform is worse than maculopapular.
I mean, I think they both are equivalent. I wouldn't be sad. I'm more upset
It's a
about the bilateral.
nondescript.
The bilateral cellulitis gets me more upset.
Okay. Oh, bilateral cellulitis?
Why is that
Yeah.
for us non-medical folk?
So a lot of times, a lot of people have issues with their legs due to circulation, right? So we see a lot of rashes on the lower leg, whether it's due to venous stasis, where your veins don't work as well to pump back to the heart. So you get almost this stasis dermatitis or like redness and ruddiness of the legs. And a lot of times, we would get consults from the ER about bilateral cellulitis, which is an infection. Cellulitis is a type of infection, and infections usually only affect one area, right? You get an infection on one leg and not both legs, right? So it'd be very uncommon to get two legs to get infected at the same time. And so we would get consults for bilateral cellulitis when we would know, in fact, it's nearly impossible to get bilateral cellulitis. You're most likely going to get something that's more systemic if it's affecting both legs.
There you go. We're learning so much
Yeah,
dermatology today. This is great. Okay. The two groups decide to hike together. All right. We're enjoying each other's company.
Make friends.
We're having a great time. All right. Unfortunately, we're not paying attention. We soon realize that we've lost the trail. We have lost the trail. Instead of retracing our steps, I, as the leader of the group, decide to make an executive decision that we will continue hiking straight ahead. All right. My reasoning is that eventually we will find civilization.
Right.
What kind of rash was this?
A rash decision.
A rash decision. He's good.
Got it.
He's
Oh,
good.
dad
There we go.
jokes.
I totally thought I'd
Took
get
a
you with that
turn.
one. Oh, man. Okay. All right. We're over halfway through here. Now, the good news is that one of the hikers in the other group brought a compass with them. So they handed me this compass to ensure that I continue walking in a straight line and not, go around in circles. The bad news is that this compass is made of 100% nickel, something
Ooh.
I am also allergic to.
Ooh, okay. So nickel dermatitis, this is another type 4 type of reaction. It's very similar to the rash that you see with poison ivy. And it's actually the most common contact allergen that exists. So, as most people are allergic to, it's the most common thing that people will develop this type of allergic reaction to. And usually red. Again, usually itchy, again, pruritic. Usually, and if it gets bad, it can be vesicular and weeping, where you get fluid coming out of it. And then over time, a lot of people will, the way that nickel works, a lot of times allergens is like it's in your belt buckle or it's in your watch or it's in your ring. And so you develop more of like a chronic type of issue with this, where it's like thicker skin, where we call lichenification of the skin, where the skin becomes thickened in this area of contact dermatitis.
Gotcha. How often do you see it when someone is lost hiking and uses a compass? Have you ever had that situation?
this type of encounter, right? If you came to me with this story, I don't
This
even
would be
know.
this would be a long
This
appointment.
would be a long visit. I take a long time in my. I'm a chatter, so all my appointments run over because I love talking to patients. It's the best part of my job.
All right. So now, so we diagnosed that. I'm leading this group because this is all my idea in the first place, and we're all now yelling at each other. Like we're all just angry or unhappy. And again, I'm not paying attention. I walk right into a thorn bush. I cut up my hands and my arms, and then fall into a decaying pile of plants and logs. And one of the people that's hiking with us, who happens to be a gardener, says, "I've done this before."
Ooh, okay. So this is something we call sporotrichosis, where you
I'm
get
afraid.
this fungus or
That's
mold
what I thought.
organism that punctures the skin and then sort of spreads. And actually, sporotrichosis spreads in a very interesting way. It spreads like almost linear up through the arm and through the lymph nodes in the arm. And we actually call that pattern a sporotrichoid pattern, which a lot of other organisms actually cause a sporotrichoid pattern. But then it's actually named after sporotrichosis because it's the most classic. Exactly. It's
Gotcha.
the OG sporotrichoid pattern that we see. So sporotrichosis from thorns, puncturing
Classic.
the skin. Classic.
All right. So we're exhausted. We're all angry. I am covered in rashes. And
Deservedly so.
again,
Right.
we decide to rest. And pretty soon we realize that it's been about 12 hours, and we're all hungry. Because nobody brought food on this hike. We thought it would just last an hour, but we got lost, and it's been 12 hours now. So in order to survive, we need to find some food. As the self-appointed leader of the group, again, and somebody who has watched several survival videos on TikTok, I decide to venture deep into the woods and search for something to eat. After some time passes, I emerge from the woods triumphantly carrying a 9-banded armadillo.
That's not where I thought that was going to
okay.
go.
Yeah.
A 9-banded armadillo. Classic finding. So this is where
Are you
you
getting
see
flashbacks
leprosy.
Are you getting flashbacks to first aid here? To studying for step one?
So actually not first aid. Like this is still relevant to our boards. So, I took boards, 6 months ago for dermatology, and these types of questions. We know everything. Derms actually treat leprosy. So those are the people that you would go to. There's a few leper colonies I think still left in the United States. Yeah. I think there's 2 left or maybe only 1 left, but there's certain, derm residencies we used to do grand rounds with that would see a ton of leprosy. So leprosy, you get from 9-banded armadillos.
Whatever that means.
Whatever that means. No one's ever seen that before. And basically actually causes you to develop these like white patches on the skin that are that you can't feel anything, like, because it damages the nerves. So they're anesthetic patches, basically, like you can't feel anything. So a lot of times they affect like the nose, the ears, and things like that, and they affect the nerves. So you don't feel anything in those patches.
Well, how unlucky of me to come out of the woods with an armadillo.
I don't know. It sounds like you could use some anesthetic properties about this point.
And so you realize exactly what's happening, and you decide to let me down gently. All right, you use your delivering bad news skills to let me know that I now have leprosy. And this has made me distraught, and the immense amount of stress from this whole experience has now caused me to develop a strange, painful rash across my midsection.
A painful rash across your midsection from stress.
In a somewhat dermatomal distribution.
Oh, so you develop shingles. I see. So now you have shingles.
Hey, you weren't thinking about it because I'm not in the classic shingles demographic, right?
You're not in the shingles demographic, but also you didn't say it stopped at midline. That's the
right.
key.
Oh gosh,
that's
you're
the
right.
key.
I screwed that up. I am an ophthalmologist after all.
So, which is actually, I saw my first shingles case as an intern. It affected the eye. So we called ophthalmology.
We do see that. That does. I really have no
this
excuse.
is something
disgusting.
Yeah, this is something you should know. This is your wheelhouse for sure. for sure. But perfect. It was perfect right down the middle.
Right down the middle.
Like classic, like textbook presentation. So those of you who don't know, shingles is a reactivation of the chickenpox virus, and it reactivates in the nerve, so it stops right at the midline before crossing over to the other dermatome on the other side. So that's shingles, which a lot of times is a painful and vesicular rash, again, of fluid-filled blisters that are red and painful in a very, very specific distribution along a nerve root.
And it can be anywhere on the body, right?
Anywhere on the body,
dermatome.
correct. And that's, knowing the nerves, because if it affects the forehead, there's a higher chance that it can affect the eye. If it affects the nasal tip, there's a higher chance that it can affect the eye. And so doctors need to know the distribution.
Man, you got this down with the eye involvement. Yeah, we pretty much anybody who has shingles in a forehead, kind of the first distribution of cranial nerve 5, any shingles in that distribution is going to end up seeing an ophthalmologist to make sure that the eye is okay. And most of the time it is, but sometimes we do get a lot of eye involvement, and it's always a tricky situation. It's not a place you want to get shingles. Kristen's really struggling with. Well, fortunately for you, we are almost done. I've got one more left. All right, you've done a great job so far. So eventually, though, we are discovered by a woodsman.
Okay.
Or woodswoman.
Or woodswoman,
a
woods person who finds us and finds me, and I'm in pretty rough shape at this point, having now had shingles and leprosy, among other things. And this person leads us to safety. We finally get to go home after an extremely unsuccessful hiking trip. And aching and sore and bleeding, I decide that I'm going to soak in my hot tub, which I haven't cleaned in 5 years.
So is this like a hot tub? So Pseudomonas can develop.
Goodness.
You end up with, hot tub reaction rash, and
Bad
it's a reaction to Pseudomonas being in your hot tub, and then you end up with
It's always about Pseudomonas with you.
Pseudomonas.
Pseudomonas. Whatever.
We see a lot of Pseudomonas ourselves
Do you really?
in the eye world. Oh yeah, we get
really?
Ulcers, corneal ulcers of Pseudomonas, and it's bad news. What does it look like when it's on the skin?
Usually purulent, pustular.
Yeah.
So vesicles are fluid-filled blisters that are clear, and pustules are blisters that are full of pus. And by the way,
tell me more.
the plural for pus is purulent. Purulent.
As opposed to pussy.
Pussy.
Correct.
Right.
Yes.
Right.
Important to know. Especially we're just full circle back to when we were reading things before we knew how to pronounce them.
Yeah. That's a rite of passage, I think, for a lot of trainees, across all of medicine is learning that fact.
Right. And pussy looks fine. It sounds fine when you say it out loud, but when you write it in a note, it doesn't sound...
M3 says it in the clinic.
Yeah.
Right, exactly.
It's something you want to avoid.
Usually purulence.
Well, I think you got pretty much all of these. I'm impressed. I shouldn't be, because you are a dermatologist after all, but you nailed all of.
He's 6 months out of training, so he's still like peak
smartness.
Peak
you
knowledge,
are brilliant.
Yes.
Yeah, you got it all still up in your head, and then just you lose a little bit every year, but you'll.
That's what Google's for.
You lose a little bit.
So that was Adventure Diagnosis, and so we'll see how successful that. If people like that game, I might play it again with other people down the road. But that was a lot of fun. Does this make you want to go hiking? Like, are you still?
No, you've convinced me that my choice to avoid hiking in nature is a good idea ultimately. So now I avoid the sun, and I have good reason to. I have other reasons,
and you avoid leprosy.
Right, exactly.
That's good. Don't pick up. And the big lesson for everyone listening is just
nature is trying to kill you.
That, but also stay away from armadillos, just in general. You don't know.
They are cute.
You don't know how many bands they have.
Well, Dr. Shah, this has been a pleasure. Thank you so much for being on with us and chatting with us and teaching us some things about dermatology. are so impressed with kind of what you're doing and educating, and people need to know a lot of stuff about their skin, and you're right there to provide it for them.
Well, thank you. And thank you for having me on and keep making people laugh. I think we need that now more than ever. Your approach, I've always appreciated. You never criticize patients. You always make the joke on us. You never single out like a particular specialty any more than you would single out yourself. And, I've always appreciated what you do. So keep doing it. I think it brings some joy in times that we're tough and continue to be tough for a lot of people that work in healthcare.
Well, thank you. There's so much to make fun of among doctors.
It really is.
So
I mean, we have fun at work, and we laugh at each other, and we laugh at ourselves all the time. And I think that's what makes it worth it. So definitely keep doing it.
Absolutely.
Before you go, though, what are you up to, and where can people find you?
Yeah, I mean, a lot of stuff, to look out for. I have some exciting things coming out, educational wise, that'll be dropping in the next couple months. So be on the lookout for that for sure. We have a lot of things we're rolling out, and we're going to continue to expand the YouTube channel. Right now we do different stuff on YouTube than TikTok. So we do like 20-minute videos on acne education and hyperpigmentation education, but we want to roll out some more information there and really try to expand on what we've already built. So yeah, continue to do that. We're building our practice out. We're expanding, we're rebranding, big rebrand coming for the practice soon in the next month or so. We're really excited about all that. So a lot of good things happening, a lot of it because of social media, it's really changed my life in a lot of ways. A lot because of the audience has been really supportive. So,
and you're the Derm doctor on pretty much all platforms, right?
Derm doctor on TikTok only. There's a story there for sure. And then Doctorly on Instagram and YouTube. So different names. Yeah.
Well, I'm sure they can find you. You're easy to find. You're everywhere. So keep up the great work. Thanks again for coming on.
Thank you for having me.
All right, let's take a look at some of our favorite medical stories sent in by all of you, the listeners. We have a couple really good ones here. So this first fan story comes from Nancy H. And I like this because it really speaks to a relationship that the very close-knit relationship that patients can have with their healthcare team here. So here's the story. I am a hospice nurse and was pronouncing a patient in a nursing home. I was sitting at the nurse's station, and Madge, one of the cranky patients, was sitting in her Broda chair. It was change of shift, and Bob, who's a rather large nurse, walked by, and Madge piped up, "You smell like ass, Bob." So Bob replied, "Screw you, Madge," although didn't use the word screw. And without missing a beat, she replied, "You wish, fat boy," and shuffled off down the hall. Comedic timing was on point that night. I love that because it's, it's like it just shows like there's a little bit of an affectionate kind of loving relationship underneath the surface. And that's,
you've got to be secure in that to be able to just,
you can tell they've been around each other a long time.
Kind of like us.
Exactly right. All right. Thank you, Nancy, for that story. Okay, here's our second one. This is from Anonymous. It's called A Mysterious Downtime at the Hospital. So for a month, one of the medical centers we served experienced a downtime at about 1:30 every morning. The IT team looked into it but found nothing and called us. We looked into it with the IT team but found no suitable cause. After a few weeks, the hospital decided to fly us out there to investigate further. But still, nothing came up. Running out of ideas, the team decided to just park themselves in the server room and see what was happening at 1:30 in the morning. The clock struck 1:30. The door opened. It was just the custodian, though, who proceeded to unplug one of the servers and use the outlet for his vacuum.
Oh.
Oh, I love it. I love hospital stories, especially ones that happen in the middle of the night. That's great.
Well, it just makes me wonder, were there no other outlets available? Why? What, if you're the janitor, what makes you think, where I'm going to go is the server room.
Well, he just, I don't know, maybe his vacuum cord wasn't long enough.
I guess.
I feel like that one's not on the custodian, though. I think it's...
I mean, he's just being resourcul, probably.
Exactly. There should have been signs or tape or something,
Yeah,
that says...
right.
Anyway.
Do not unplug the hospital.
Who knows? But I love that. That's a good one. All right. So if you have a story from your experience in healthcare as a patient, as a doctor, nurse, whatever it may be, send it to us at knockknockhi@human-content.com. We'd love to hear from you. Well, that's our show for today. That was great.
Yeah, that was super fun.
It was awesome talking with Dr. Shah. He's
someone who's not you.
That's right, who actually knows something that I don't know anything about dermatology. Despite it being the largest organ in the human body, I feel like I should know more. But you can say that about any organ.
Right, and we all have it, so
that's
we
exactly
should all
right.
know something.
That was a lot of fun. And thank you again for the stories. Don't forget to share with us your thoughts, what we talked about today, what you liked. Did you like Adventure Diagnosis? I thought that I had a lot of fun doing it. I didn't tell you ahead of time.
No, I was afraid of where
be.
that might go. So it sounded like you had a rough hike.
I did, and we didn't let Dr. Shah know that I was planning.
Yeah, that was a big pop quiz.
And he did phenomenal.
Did great.
Yeah. It's no one can talk about rashes like a dermatologist.
It's true.
Could honestly listen to it. Probably like 30 minutes before I'd get tired of it. But honestly, it's good.
I think my threshold would be a little sooner than that.
You were a little bit more nervous about it because
I didn't know
skin
where it was
stuff.
Really, any medical stuff.
Any medical
Bodies
stuff.
are gross. I mean, they're cool, but they're gross.
All right. Well, and also, so let us know. Is there a doctor that we should invite, an influencer, anybody that we should invite onto our show here? There's lots of ways to hit us up. You can email us knockknockhi@human-content.com. Visit us on our social media platforms. We're on Twitter, Kristen and I, Dr. Glaucomfleckens. You can find me on TikTok, YouTube. We're all over the place.
I'm Lady Glaucomfleckens, mostly on Twitter.
That's right. And kick it with us and our Human Content Podcast family on Instagram and TikTok at Human Content Pods. This is a brand new podcast, so leave us a review. We always appreciate it. We want to hear what you think. Give us your feedback. And if
what are you hoping to see?
And please subscribe and comment on your favorite podcasting app, wherever you're listening to us, or on YouTube, and we might give you a shout out. Yeah. So let us know what you think. You can see us every week on YouTube if you'd rather watch us than listen to us.
But yeah, if you're joining us now, you're getting in on the ground floor. These are our OG listeners.
This is it. You are right here at the beginning.
Yeah.
And it's a lot of work's gone into getting this to work, and most of it's just me trying to figure out our technical setup.
It's true.
Fortunately, I have Kristen here to help me with that. And just a reminder, we have a Patreon. Tons of cool perks. Bonus episodes are coming. Where we react to medical shows and movies. Come hang out with us. Come hang out with the Knock Knock Hi member community. We are active in it, and we want to see you there. Early ad-free episode access for Patreon members, interactive Q&A, live stream events. Who knows? We may come up with more stuff.
Yeah, we have a lot of fun.
I don't know. It's just like, this is what we do. Just come up with things, and we will be creating this just awesome community. I'm excited about it.
Yeah.
And so that's patreon.com/Glaucomfleckens, or you can go to our website, glaucomfleckens.com. You can find all the information there. Thanks for listening. We are your hosts, Will and Kristen Flannery, also known as the Glaucomfleckens. Special thanks to our guests today, Dr. Muneeb Shah, the Derm Doctor. Our executive producers, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brook. Our editor and engineer is Jason Cortizo. Our music is by Omer Benzvi. To learn about Knock Knock Hi's program, disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, it's a lot of legal stuff there. You can go to our website, glaucomfleckens.com, or reach out to us at knockknockhi@human-content.com with any questions, concerns,
Or fun medical puns.
or if you have a pun. Yeah, we'd love to hear it. We love jokes. Puns, they're okay. But Kristen loves the puns, so please give the puns to us. Knock Knock Hi is a human content production.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.